Welcome to Ortho Eval Pal, where we help you build confidence in your orthopedic evaluation and management skills.
Hi, my name is Paul, and I'd like to talk to you today about a common foot problem called metatarsalgia and another common foot problem called Morton's neuroma, and how to distinguish between the two of them. We'll talk a little bit about how a person develops metatarsalgia and Morton's neuroma, and also some pointers on how to treat it. When somebody comes in and complains of a burning sensation to the ball of the foot, and occasionally the sensation of a quote-unquote rock being underneath the forefoot, that's commonly a complaint of metatarsalgia, which is an inflammation between the distal metatarsal phalangeal joints of the second and third metatarsals. Morton's neuroma is more common between the third and fourth, and when I palpate for these, I usually palpate quite deep at the metatarsal head distally on both of them and in between the two of them. Morton's neuroma will more commonly cause paresthesia into the toes, which metatarsalgia will not. Some of the other contributing factors are people who have a pes cavus or high arch foot deformity, because they're putting a lot more pressure at the distal metatarsals when they walk. Another significant contributing factor is a tight gastrocsoleus complex, which increases the plantar pressure here when the knee is in full extension and the patient is in the terminal stance phase of gait. And so that can put an excessive amount of pressure there. Another thing I look for is transverse metatarsal arch. Oftentimes these folks who have these diagnoses will have a reversal of that transverse metatarsal arch and distribute more pressure between the second, third, and fourth metatarsal heads, causing excessive pressure there. And oftentimes you'll see a callus formation there also in folks who have that diagnosis. So the way I like to treat this is, number one, optimize gastrocsoleus flexibility as much as possible, especially with the knee in full extension, typically with a slant board, because that distributes pressure equally throughout the foot, and you can get a nice calf stretch with that. The other thing I like to do is place the patient in an orthotic where I can place a metatarsal pad just behind the metatarsal head to offload it, to basically produce like a cliff so that the second and third metatarsal heads don't strike the ground so much. And with that metatarsal bar, I like to make it thicker in the middle and thinner on both sides, so it helps to reestablish this transverse metatarsal arch. Another very important aspect is proper footwear, not walking barefooted too much, and a shoe that is not too tight is important, along with a shoe that doesn't have a very high heel to it. So trying to cushion this and letting it settle down, decreasing the inflammation, is extremely important. Metatarsalgia responds really well to conservative management and orthotics. Morton's neuroma is a little more difficult to treat, and oftentimes will require injection and or surgical intervention when they become really severe. I always caution people to not let the Morton's neuroma linger too long, because chronic compression on the nerve can cause some permanent nerve damage and long-term pain. So that's how I would manage and decipher the difference between Morton's neuroma and metatarsalgia. Thanks.
We hope you've enjoyed this video, and for more awesome content, go to orthoevalpal.com. Can't wait to see you there.